Evet, teşekkür ederim.
Thank you very much, Mr. Chairman, and I'd like to thank the organizing committee of this Congress. Well, the previous speech has preempted most of what I would like to say on this, but I'm going to make some additions based on my own experiences. First of all, there might be differences in personal approaches, but we have to understand that schizophrenia is a chronic disease, and like other conditions, we can't simply say let's use it for 1 or 2 years and then we can maybe discontinue. This we can't say in theory, because when I review patients over the years, in all the patients where I discontinued the drug or tried to lower the dosage, I ran into exacerbations, and there has been no patient which I have been able to discontinue. If clinical psychology tells me this, I can't really believe the books which are saying I will try for up to 5 years and then I will stop. And this is what we've been teaching the students, but in my own experience, and I believe in the experiences of many people here who've been seeing schizophrenia patients, and there are no patients in which we could stop these drugs, and there is no practical value, there is no clinical value in saying this is possible, and it's not realistic. And so at the very beginning I tell my patients this disease is like diabetes, and like diabetes patients, you will not be able to stop taking these drugs. It's about the brain, and it's a disease of the brain, so I have to prepare the patient. So we tell the patient, let's use this drug or not. Or we want to increase compliance to treatment and make sure they use at least 1 drug or maybe 1 injection. These are the drugs that came out of a patient's bag. When they came for treatment, we are doing a lot of polypharmacology, and we're prescribing too many drugs to the same patients. And another thing is we're still expecting some good to come from magic. The picture on the right is from Prague, the picture on the left is from Turkey, and we would visit shrines and tombs, and we will tie ribbons on trees and make wishes. And these people, they want you to give them drugs, and they want to just get better without making any effort. So it has many different dimensions, what we're talking about here. So most important is this psychosis is dysfunctioning of insight and inability to assess the reality. If a patient in this condition, how can you explain to them the importance of compliance? How can you keep them in treatment? Of course we have patients who are compliant, but looking at the majority and seeing that the disease is progressing with repeating episodes, then we have to admit certain things, and we can't simply say this is the compliance ratio, this is the dropout ratio. What we need to do is we need to very aggressively, very radically charge against the patient, against the disease, and if I was a patient, I would come sweet talk you into giving me drugs, and then I would go home and I would not take them at all. And so don't believe as a physician when I tell you I'll use this drug. And the major part of our patients are partially non-adherent, non-compliant, and 40% is fully non-compliant, and a very small part of those people are fully compliant. This is what the clinical practice shows. A loss of insight means and non-compliance with the treatment. It will worsen the prognosis. Why do we have to be aggressive? Because as long as the disease stays in the brain, the functionality of the patient will worsen, and therefore we need a more structured and active approach in order to get the patient to comply. Cost is very important. The cost coming from repeating, and each time the disease relapses, the ones that suffer the most are the family and the close environment. There are two important factors we run into. One is the persistent side effects. The second one is a lack of insight. But although these two are on the foreground, each patient may have their own specific reasons for non-compliance. And I think there is something we overlook from our own perspective. The factors affecting the relationship between the patient and the treatment. As a physician, as a therapist, or as a curer, what are we doing to make sure that there is compliance? If we're doing nothing other than explaining the drug, explaining the side effects, then non-compliance is almost inevitable. And so the physicians are not just the people who give this information. They must have a target to ensure compliance, and social support is very important. Many families are failing to give social support to the patient in those cases where there is non-compliance. Substance abuse and negative attitude toward treatment are other important reasons. If we can ensure treatment compliance, if we can apply psychosocial treatments, and if we can continue with the rehabilitation services, there is an increased chance for good functioning, quality of life, and decrease of burden and cost. So our approach should include the psychosocial approaches and elimination of bias on the part of the patients and their families in relation to the treatment. Therefore, we need to train them. Definitely, we must do this, and so the main goal in all such diseases is to increase insight. That is to ensure the survival of the patient and make sure that the patient is in control of and is managing his own treatment, and that is going to decrease the cost, that is going to increase the quality of life, that is going to reduce the burden on the family and the immediate environment. And there are, of course, different dimensions of insight, like the example of Amador, whose brother didn't believe he was sick. And there are some patients who are compliant, but they have problem with insight. They don't think they are ill, and this is not a problem as long as they can take these drugs and comply with treatment. But does that solve the problem? No, because they are still ill. So we must have our goal to improve those patients, and of course, if the patient can understand the social consequences of this illness, then he or she will be more willing to take part in any efforts to overcome the disease. But we should always remember that just like the patients have insight problems, the families have insight problems too, and there are studies proving that. We are talking about training the family, and that is indeed important, but we need to approach the family keeping in mind that they might have distorted insights as well. I'll give you one example. We have schizophrenic patients with severe physical diseases, and we're having difficulty taking them to physical treatment or rehabilitation, and the family is not really very eager to take them, and the family is not cooperating with you. You want the family to give the patient 10 milligrams, they're giving 5 milligrams. You tell them to give 15 milligrams, they give the patient 10 milligrams. So they can't really grasp the dimensions of this disease as good as we can do it. Of course, they are the ones suffering from the disease, but they don't really understand. And we assume that whatever we tell the patient relatives, they can really understand, but they can't. I mean, we have received years and years of education to be able to understand these diseases and conditions, and how can they learn it in such short time? And, therefore, we need to have in place training programs for changing the attitude of family and patient relatives. Stigmatization is another problem. It's important both for the patient and for the family. Using a drug regularly is difficult for the patient, while monitoring the use of a drug by the patient is difficult for the family. So we need to always teach the family and the patient about the importance of stigmatization, and especially internalized stigmatization. The psychosocial treatment program is, as you can see on the slide, and some practices are more important here. One is family interventions, and we had covered that, why is it important, and it's a method for changing non-functional behaviors and thinking. It is cognitive behavior therapy, and it is to help the patient understand his condition and start managing this. And the classical cognitive behavioral therapy should be adapted into adherence therapy, compliance and adherence therapy. And In this case, the CBT is applied only for the purpose of increasing treatment compliance and adherence, but they're not really that effective. Again, APA, NICE, and PORT are recommending these treatments. We'll have to keep in mind that assertive community treatment is good for many treatment-resistant patients with frequent episodes and with no one around them to help. But in our country this is not available, so 24 hours, anywhere, anytime. When the patient has an episode, they discontinue the drug. A mobile service is going to find the patient on site and is going to take care of them. There is a great need for such teams, and case manager approach is also important and useful. We know that in almost 1/3 of all the patients, family support is not enough. For such patients, case managers can emerge as a profession in which each case manager can take care of 20 to 50 patients, and these practices are proven to increase patient compliance. And when these teams start working, when these professionals start working as a part of assertive community training, then I'm sure we're going to see some better results. And here are the common elements mediating the therapeutic efficacy: psychoeducation to the patient and family, motivational techniques, increasing motivation for treatment, improving interpersonal relations is very important, and of course, in doing that, supporting the patients with a case manager or assertive community services. How do we motivate the patient? And actually, it's difficult to bring the patient in for examination, and if necessary, you can go to visit the patient at his or her home, and exploring ambivalence toward medicines, and you can review illness history, identify patient's attitude toward medication, and to weigh the advantages, disadvantages of treatment with the patient, and discuss the benefits of longer-term medication use, and to hold several sessions just to do that. And the patient may have delusions and hallucinations, sleep disorders, other symptoms. We can focus on some of the symptoms which the patients can understand better and use it as a source of motivation for increasing drug compliance. A trusting relationship is very important. I'll give you an example. When we were using in the day hospital care services, a nurse took onto herself the treatment to caring of the patients, and in half of my patients I use injections in schizophrenia. When we first saw the atypical antipsychotics, I used all of them on my patients. Risperidone came out, and I used risperidone 2 months, and then olanzapine, ziprosidone, quetiapine, and the patients always come with their families, and the patient says, I'm taking these drugs, and the family says they're giving the drug, but they're not getting better. I did one trial and I gave only prolixin. It was only 7 lira, the other one was 100 lira, 200 lira. So I tried an injection, to see if these people were doing it. In the first month I did every week, in the second month I did every other 2 weeks, and I did injections every other 3 weeks in the third month, and the pulse scores improved significantly. So there are patients in practice who are not using the meds, and many expensive drugs, people are not using these drugs. We think we are treating them, but actually we are not treating them. So recently, in terms of treatment resistance, the specialists agree that, let's say you used an oral antipsychotic and you used a second one, again oral, and then you would switch to clozapine. And now they say at least one of the 2 antipsychotics used must be injection treatment. I have adopted that for years in my clinic. And without injection, which guarantees the use, we can't say that the patient is treatment resistant. Of course, different methods are used, and pain-centered antipsychotic medication adherence intervention. This is about getting the patient to decide and to ensure the participation of the patient in the treatment, convincing him or her, explaining the benefits of medicine use. From the patient's perspective, what are the obstacles for compliance? You might want to review those obstacles, and you might ask yourself what you can do to eliminate or reduce those obstacles, what are the motivators, and you can work with the patient and the family. Of course, increasing compliance behavior and attitude of the patient is actually possible. Case management and assertive community treatment, very important. Sometimes we don't have enough time working at the clinic, but a nurse who specializes in this area can easily work on patients' compliance. Trusting relationship is very important. When the patient trusts the physician, and they can be compliant even in the worst times. So the studies tell us certain things, because the patients who come for these trials, who participate in these studies, are already patients with insights, and they have already agreed to comply with the treatment. So it doesn't mean anything, doesn't tell us anything about the actual situation related to compliance. So the differences between studies, trials, and the real life can be really huge. And from my own perspective, to ensure compliance, you need to use depot injection, long-acting injectable drugs. It's very important for increasing compliance. And secondly, you need to closely monitor the patient for treatment-patient relationship and for side effects. Creating trust relationship and continuity, very important. The patient and the relatives must be trained, they must be motivated, because there is insight-related problems in both patients and families, so we should never get tired of training them. Family interventions should never be overlooked. A week, 15 days, a month, we see them 15 minutes. The families are living with them all the time. If we train the family very well, they can be a good treatment support for us. And fourthly, there are still patients who don't use any medication, no insight, no family, or the families with insight problems, but they can't come, they don't come for trainings, and for them you need to have maybe compulsory treatment. What we do is we introduce a treatment obligation. We use law enforcement officers to bring them every month. We bring them and we treat them. So right at the beginning of the treatment, you must adopt a team approach to ensure treatment compliance following a very aggressive, serious approach. Thank you very much.